Jerry, who is pursuing his final year in DM Neuroanesthesiology at Jipmar, Pondicherry. So I welcome Dr. Jerry to start his presentation. Dr. Jerry worked previously at Father Mother Hospital for a period of 1.5 years before he was doing his DM Neuroanesthesiology. Currently, he is in his final year at Jipmar, Pondicherry. Over to Dr. Jerry. Jerry, are you there?
Yes, sir. Yes, sir.
Yeah. Share your screen and start your presentation.
Able to see so now, sir?
Yeah. We are able to see your screen.
Good evening to all. First of all, let me thank Kiran sir, Balabhaskar sir, for providing me an opportunity for this lecture, rather a class. So I'll be discussing about management of pituitary tumors, anesthesia management, and the preoperative evaluation. So coming to introduction, pituitary region, it's a confluence of neuroendocrine and ectodermal tissues, and it has a portal circulation between the two critical venous plexus, and it is the osseous junction of the three cranial fossas, the anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. So introduction, pituitary region, it's a confluence of neuroendocrine and ectodermal tissues, and it has a portal circulation between the two critical venous plexus, and it is the osseous junction of the three cranial fossas, the anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. So introduction, pituitary region, it's a confluence of... Hello, sir. Am I audible, sir?
I think, Dr. Jerry, there is some background video is playing. Dr. Jerry, some background audio and is playing again.
So I am hearing my sound again.
Yeah, that is what some audio is being played.
No, sir.
Okay, I think now it's fine. Everything is fine. I think you can continue.
Yes, sir. Yes, sir.
Yeah.
Now we can restart, I suppose.
Yeah.
Yes, sir. Yes, sir.
You can share the screen and yeah.
Now, sir.
Yeah.
Yes. Make it a slideshow and start.
Yes, sir. So pituitary tumors, they differ fundamentally from other tumors of the intracranial origin. So they might be active tumors where they secrete tumors, or they might be inactive tumors where they will not produce any tumor, endocrinology not active. So coming to epidemiology, pituitary tumors are more commonly seen in females, and the highest incidence, but in between 55 to 85 years, the incidence is more in men. When taking, the functioning tumors are more commonly seen in younger adults, and with increasing age, non-functioning tumors are most commonly seen. So when we speak about pituitary tumors, when we get the diagnosis for surgery, it will be either as a pituitary microadenoma or a macroadenoma. So the distinction is made on size. So if it is less than 1 centimeter, it is a microadenoma, or if it is more than microadenoma, 1 centimeter, it is a macroadenoma. So it does not account for the variability in size, the extension, and the growth characteristics. So for the extension of the tumors, there are different classifications, like Hardy's classification for supracellular extension and Wilson's classification for the extracellular extensions. So in the MRI report, we may be seeing the classification, Hardy's classification and Wilson's classification, when the tumor extends from the cellular region to extracellular region. So the another classification is the Knosp classification, where when the tumor has invaded or extended out of the cellular region and has reached near the cavernous sinuses or the eyes or near the internal carotid artery. So the clinical presentation of pituitary tumors is important because mainly the 5 types of presentations are there with pituitary tumors. It can be a person can present as pituitary hyperfunction, pituitary insufficiency. Patients can present with mass effect, with pituitary apoplexy or incidentalomas. So coming to pituitary hyperfunction. So this is due to excess hormonal secretion from the pituitary tumor. So this depends upon the hormone which is mainly secreted. The symptoms of the patient varies according to that. So if it is a prolactin secreting tumor, the patients will present with amenorrhea, galactorrhea. With growth hormone secretion excess, patient will present with acromegaly or gigantism. ACTH secretion, patient with present with Cushing's features. And TSH secreting tumor, patient might present with hyperthyroidism. So the next presentation is pituitary insufficiency. So this happens due to the tumor increasing in size, compressing the normal pituitary tissue. So usually what happens is that anterior pituitary failure happens with this phenomenon. It is very rare to cause a posterior pituitary failure. If the patient has a posterior pituitary failure in the preoperative evaluation, we have to think for an alternative diagnosis. So the sensitivity of the cells for susceptibility with when compression, the most sensitive is gonadotropes, then followed by thyrotropes, then somatotropes, and finally corticotropes. So the next third presenting feature will be with mass effect. These patients may present with or without coexisting endocrinopathy. And the most common symptom will be headache, which is due to stretching of the diaphragm sellar. And the most common objective symptom will be visual field defects. And the most commonly seen is bitemporal hemianopia. So with increase in size of the tumor, it can grow suprasellar, it can cause compression of the hypothalamus, and it can cause disorders of sleep, eating disorders, alertness disorders, behavioral and emotional disturbances, and it can enlarge upwards, and it can compress the floor of the third ventricle, and it can cause obstructive hydrocephalus, and patient can present with symptoms of raised ICP. Plus, if the tumor extends laterally into the cavernous sinuses, it can encroach upon the nerves, 3, 4, and 6 cranial nerves, and patient can present with cranial nerve palsies, where you will see involvement of extraocular muscles. Then if the tumor increases in size, and it can compress the medial temporal lobe, and in such cases, the patient may present with seizures also. So one phenomenon seen with pituitary compression is Stalk effect. Stalk effect happens when the pituitary stalk is compressed by the growing tumor. This causes inhibition of release of dopamine from the hypothalamus. So this can cause an increase in prolactin secretion, and can cause this can mimic like prolactinoma, or when we analyze when we do blood investigation, the prolactin levels will be high. So in Stalk effect, the prolactin level will be usually less than 150 nanograms per ml. Usually any tumor involving the cella can produce this effect. So if the levels of prolactin is more than 200 nanograms per ml only, then we have to suspect a prolactin producing tumor. And if it is less than 200 nanogram per ml, the diagnosis should be doubtful. It can occur due to any cellular mass. The next presentation is pituitary apoplexy. It is usually a clinical syndrome. The patient may present with acute onset of headache and visual impairment, usually after an intralesional hemorrhage into the pituitary. So these are the clinical syndrome. You will get the confused and agitated patient. Usually the vitals will be stable. On fundoscopy, bilateral papilledema is seen. Visual field defects will be there. Visual acuity will be reduced. Bitemporal hemianopia can be seen, and rest of the examination might be unremarkable. So these are the clinical features of pituitary apoplexy. So the exact cause of pituitary apoplexy is not known. It can be due to ischemic necrosis of a rapidly growing tumor, or due to an intrinsic vascular abnormalities which is peculiar to pituitary tumors, or due to compression of the superior hypophyseal artery against cellular diaphragm. So the next presentation can be an incidentaloma when patient has undergone some routine brain imaging. So in this condition, patient may not always be symptomatic, and in 15% of the cases, it is associated with endocrinopathy. And the decision to treat an incidentaloma depends on the size, symptoms, and the other medical condition of the patient. So this table shows the features of sellar mass lesion. So it can cause from the pituitary, it can cause, if it is a functioning tumor, it can cause hypogonadism, hypothyroidism. Then if it causes compression of the optic chiasma, visual field defects happen. If it impinges on the hypothalamus, it can cause emotional disturbances, temperature dysregulation, sleep disturbances, and autonomic dysfunction. Then if it extends laterally and invading the cavernous sinus, patient will present with the ophthalmoplegia with cranial nerve 4-6 involvement. Then frontal lobe involvement can happen. So the goals of pituitary surgery is to relieve the mass effect, normalize the excess hormone secretion, minimize tumor recurrence, and preservation or restoration of the normal pituitary function, and procurement of a histopathological diagnosis. So these are the various surgical approaches for pituitary surgery. Most commonly used to perform is endonasal submucosal transeptal transphenoidal pituitary tumor decompression, endoscopic transphenoidal pituitary tumor decompression. So preoperative assessment, we have to take a proper history of the patient, including the symptomatology, how the patient presented. History-wise itself, we can arrive at a diagnosis whether it is a secreting tumor or a non-secreting tumor. Clinical examination is important. We can see whether the patient has any gigantism or acromegaly, or whether features, Cushing features are there or not. Then imaging and hormonal profiling of the patient has to be reviewed. So when taking history of the patient and or examining the patient, we should know that pituitary tumors are associated with other syndromes. So MEN1 is associated with pituitary adenomas. MEN4 is associated with pituitary adenomas. Carney's complex is also associated with pituitary hyperplasia and adenomas, and familial pituitary adenoma is also there. So we should be aware of all these 4 syndromes where pituitary adenomas is also associated with this. Now coming to endocrine diagnosis, we should review the preoperative endocrine investigations. Then coming to prolactinoma, the most common tumors are secreting tumors are prolactinoma. The incidence is around 30%. Usually the anesthetic management of prolactinoma is less problematic, and most commonly the management is medical management. So these are the signs and symptoms of prolactinoma. The most commonly patient presents with amenorrhea, oligomenorrhea, or infertility for evaluation. So prolactinoma can present as microadenoma or macroadenoma. These are the symptoms. In females, they can present with secondary amenorrhea, menstrual irregularities, or infertility and galactorrhea. In males, impotence, decreased libido, infertility, and galactorrhea. So the diagnosis is mainly the measuring prolactin levels. If it is more than 200 nanogram per ml, the diagnosis of prolactinoma is established. Now the treatment, as I already mentioned, the treatment is mainly medical treatment by dopamine agonists like bromocriptine and cabergoline. The next anesthetic challenge is growth hormone secreting tumor. This can produce gigantism and acromegaly. Gigantism occurs if the secreting tumor happens before epiphyseal closure, and acromegaly, if it occurs after epiphyseal closure. So these are the features of acromegaly. So in the here we can see musculoskeletal system. You can see prognathism, jaw malocclusion, carpal tunnel syndrome. Then in cardiovascular system, acromegaly can cause left ventricular hypertrophy, asymmetric septal hypertrophy, cardiomyopathy, hypertension, congestive cardiac failure. These patients have obstructive sleep apnea. Then visceromegaly will be there. Large tongue, large thyroid, thyroid enlargement may be seen. Hepatomegaly can be seen. Then these patients have impaired glucose tolerance will be there. Hypertriglyceridemia. Then hypercalciuria. Electrolyte abnormalities are also seen with acromegaly or gigantism. So the diagnosis is mainly by measuring the growth hormone levels. If there is the growth hormone levels will be more than 5 nanograms per ml if it is a growth hormone secreting tumor. Then the diagnosis can be confirmed by oral glucose tolerance test by administering 75 gram glucose tolerance and measuring the growth hormone. So if there is growth hormone secreting tumor, there will be the growth hormone secretion will not be suppressed with 75 gram oral glucose tolerance test. The other test is by measuring the insulin-like growth factor 1 levels for the particular age. So this is the diagnostic chart for acromegaly. So first we'll be measuring the IGF-1 level. If it is elevated, we can do an oral glucose tolerance test and measure the growth hormone levels. If there is inadequate growth hormone secretion, we will arrive at a diagnosis of growth hormone secreting tumor. So we have to evaluate for pituitary tumor. So we can do a pituitary MRI and see whether there is any pituitary mass. If it is not there, if it is due to an extra pituitary secretion. So the next common is ACTH secreting tumors. The incidence is around 10 to 15%, and these patients presents with Cushing-odd features. So if it is a pituitary secreting tumor producing Cushing syndrome, then it is known as Cushing syndrome, Cushing's disease. Or if it is due to an ectopic ACTH producing tumor, it becomes a Cushing syndrome. So the important thing is that these tumors, when it is producing from the pituitary ACTH secreting tumor, these tumors retain partial suppressibility in the presence of high doses of administered glucocorticoids, because that axis is still maintained. So these are the features of Cushing syndrome. We can see buffalo hump, stretch marks, thinning of hair, round moon facies. So hypertension is seen in almost 75% of the patients. Then the patients might be diabetic. Then these patients have proximal muscle weakness, obesity. Then osteoporotic changes are seen in 40% of individuals. Hyperpigmentation. Then hypokalemic alkalosis may be seen in 15% of the individuals. So in hematopoietic system, we will see leukocytosis, lymphopenia, and eosinopenia may be seen. If it is an ectopic ACTH producing tumor, there will be rapid development of hypercortisolism with hyperpigmentation. The other features are hypertension, hypokalemic alkalosis, glucose intolerance, and edema are more pronounced in those patients where there is ectopic ACTH level production is happening. Then serum potassium levels are less than 3.3 millimoles per liter are evident in 70% of the patients with ectopic ACTH secretion, but are seen in less than 10% of the patients with pituitary dependent Cushing syndrome. So these are the differential diagnosis of Cushing syndrome. 80% is due to ACTH dependent Cushing syndrome. It can be due to a pituitary lesion or due to an ectopic ACTH secreting tumor. Or another 20% is by ACTH independent tumors like adrenal adenoma, nodular adrenal hyperplasia, or pseudo Cushing-odd states like exogenous steroid administration, alcoholism, obesity, or polycystic ovarian syndrome. So the diagnosis is mainly by measuring urinary free cortisol level, then low dose dexamethasone suppression test. So usually when there is hypercortisolism, with low dose dexamethasone suppression test, there will be failure to suppress cortisol secretion. So, or the other test is midnight serum or salivary samples of cortisol estimation. So this is the algorithm for diagnosing pituitary hypercortisolism. So when you are seeing a Cushing syndrome, either you can do a 24-hour urinary free cortisol or low dose dexamethasone suppression test. That is 1 milligram of dexamethasone suppression test. If it fails to suppress cortisol secretion, then we can go in for then we will arrive at a diagnosis of Cushing syndrome. So the next one is measuring the ACTH levels. The ACTH levels are suppressed, then it is due to we have to go for CT of adrenals, and ACTH levels are detectable or high, then we have to go for the diagnosis is an ACTH dependent disease. Then we have to go for high dose dexamethasone suppression test. So with high dose dexamethasone suppression test is by 2 milligram 6th hourly for 48 hours, and after that we will measure the cortisol levels. If it fails to suppress the cortisol secretion, then it is due to an ectopic ACTH secreting tumor. Or if the cortisol secretion is decreased by more than 50%, it is from the pituitary ACTH dependent pituitary tumor. So these are the differentiating features from of ACTH secreting pituitary tumor and ectopic ACTH secretion tumors. So both cases you will see hypokalemic alkalosis, but it is more commonly seen in ectopic ACTH secreting tumors. Basal ACTH levels will be inappropriately high in both cases, and with dexamethasone suppression test, ACTH both it will not be suppressed, but high dose dexamethasone suppression test, if it is from the pituitary, the cortisol level will decrease, but if it is an ectopic ACTH secreting tumor, the cortisol level will not decrease. So next is TSH secreting adenomas. These tumors are usually rare. They can present with hyperthyroidism or hypothyroidisms. So these are mainly the screening tests for pituitary tumors. So the preoperative assessment, we have to review the hormone levels. We have to review the endocrine diagnosis. We have to do visual function analysis, and we have to see whether there is any evidence of raised ICP and associated comorbidities like diabetes mellitus or hypertension. Then if there is males with low testosterone levels have shown to present with increased incidence of anemia. Then if it is associated with MEN1 syndrome, hypercalcemia incidence is more, then we have to continue all hormonal replacement therapy preoperatively. And if the patient is prepared for endoscopic surgery in the preoperative period, we have to instruct the patient preoperatively for that after the surgery. Nose will be packed, so we have to you should instruct the patient to breathe through the mouth after the surgery. So if the patient has acromegaly, this will be always challenging to the anesthesiologist because multiple factors are there. It can cause difficulty with mask ventilation, difficulty with intubation also. So the problems with acromegaly are that there will be overgrowth of soft tissues of oral cavity, laryngeal muscles, and hypertrophy of the mandible. Then macroglossia, prognathism, and malocclusion are seen. Then they are prone for airway obstruction because there will be reduced size of glottic opening. Then hypertrophy of the periepiglottic folds are seen, calcinosis of the larynx, and recurrent laryngeal nerve injury is also seen. So, and also respiratory disease is the second most common cause of mortality after cardiovascular complications in acromegaly patients. If the patient has hoarseness of voice in the preoperative evaluation period, we have to suspect recurrent laryngeal nerve palsy or laryngeal stenosis, and we can advise for an indirect laryngoscopy. These patients has visceromegaly. These patients might have goiter in 25% of the patients and might cause tracheal compression also. So this can also cause hoarseness of voice also. Then we have to review the X-ray neck of the patient, and flow volume studies are also helpful. These patients also has obstructive sleep apnea, 70% in males and 25% in females. So this will increase if the patient has any other compromised airway features. And we have to be careful when administering narcotics and sedatives to these patients. Then cardiovascular manifestations. These patients have hypertension due to positive inotropic effect of IGF and change in response to angiotensin II receptors. Myocardial hypertrophy is seen, interstitial fibrosis also seen. So an echo can be helpful in these patients. Then Cushing's disease, these patients have hypertension in 50% of the patient. The diastolic pressure may be more than 100 millimeters of mercury. Multiple factors are responsible for this. It can be due to increased renin-angiotensin-aldosterone system, or this increased cortisol can cause increased cardiac output and increase in hepatic production of angiotensinogen. Then these glucocorticoids can cause decrease in synthesis of vasodilatory prostaglandins. And these patients have increased sensitivity to exogenous catecholamines. So all these factors predispose these patients for increased incidence of hypertension. In ECG, we will see high voltage complex, inverted T waves may be seen, LVH and LVH with strain pattern may be seen. In echo, we can see diastolic dysfunction, asymmetric interventricular septal hypertrophy. And these features usually regress following the surgery. And in these patients also, they have obstructive sleep apnea. So these patients might have exophthalmos. So we have to take care to prevent corneal injury. Thinning of skin and easy bruisability is seen. So cannulation might be difficult. Then myopathy of the proximal muscles are seen. Osteoporotic changes are seen. These patients are obese and high incidence of gastroesophageal reflux disease. Now coming to perioperative steroid management. These patients, there is always secondary adrenal insufficiency can happen. So this is due to a decrease in corticotrophic releasing hormone or ACTH secretion, or due to HPA axis suppression. Usually only glucocorticoid deficiency is seen. So the diagnosis can be established by measuring the cortisol level. If it is less than 20 microgram per deciliter, we can think that there are chances of adrenal insufficiency, and we can confirm it with ACTH simulation test, or by administering synthetic ACTH 250 microgram. After administration of ACTH, if the rise in cortisol is not increasing, or if it is less than 20 microgram per deciliter, then we can arrive at a diagnosis of HPA axis suppression. And these patients are more prone for secondary adrenal insufficiency, and they require perioperative steroid supplementation. So if these patients have hypopituitarism, usually hydrocortisone is given 3 doses, 100 mg, 1 dose on the evening of the surgery, 1 dose before the on the morning of the surgery, and the 3rd dose after the surgery. If ACTH stimulation tests are abnormal, hydrocortisone is started 15 to 30 mg daily. And usually to counter the stress with during the surgery, supraphysiological dose is needed 48 hours perioperatively. And if the patients have normal ACTH stimulation test, steroid coverage is not required. And if the patient has Cushing syndrome, steroid coverage is required perioperatively. So this is the protocol for perioperative steroid management. And if it is a superficial surgery, 25 mg IV, minor surgery 25 mg IV, moderate surgery 50 to 75 mg, and taper over 1 to 2 days. If it is a major surgery, 100 to 150 mg IV, and taper hydrocortisone over 1 to 2 days. Now coming to airway management in acromegaly and Cushing's disease might be challenging. The 4 grades are there in acromegaly. Grade 1, when there is no involvement of airway. Grade 2, when there is nasal or pharyngeal mucosal hypertrophy of vocal cord and glottis. And grade 3 is glottic stenosis or vocal cord paresis. And grade 4, combination of grade 2 and grade 3. So it has been recommended that in grade 3 and grade 4, we have to go for tracheostomy. But nowadays it is not practiced because fiber optic bronchoscopy is easily available. So if it is the grade is grade 3 and 4, it is always better to go for fiber optic bronchoscopy for securing the airway. So next is when the nasal mucosal preparation, usually the nasal mucosa will be prepared with vasoconstrictor agent, xylocaine with adrenaline or xylometazoline. So during this time, hypertensive response can occur when nasal mucosal preparation is being done. Then the most important thing is optimizing the surgical exposure. There are various methodologies to increase the surgical exposure. So one is placing a lumbar drain. So this is done before the surgery. A lumbar drain is placed, and through the lumbar drain 10 to 20 ml of air or saline is instilled, so that the suprasellar is so that with pushing saline or with air, this can cause the suprasellar contents are pushed down, and more exposure of the pituitary gland happens. So this is why preoperative lumbar drain is placed. Then, or by giving Valsalva maneuver. So during the surgery, surgeon might ask you to perform Valsalva maneuver so that the pituitary is more easily accessible. Then, or Kukensted's maneuver by compressing the IJV, and or controlled hypercapnia. So this is one among the surgeries in neurosurgery where you can go for hypercapnia, a controlled hypercapnia. Around 46 millimeters of mercury is recommended, because this can cause a brain bulge, and this can help in surgical exposure, and this can facilitate maximal removal of the pituitary tumor. So coming to monitoring, All routine ASA standard monitors are required. Then invasive arterial line is usually recommended, and central line monitoring placement is dependent on the patient's comorbidities. So the anesthetic goals are airway management. This might be challenging in patients with acromegaly or hypercortisolism. Then hemodynamic control during endoscopic surgery. During the nasal phase, we may have to go for hypotensive anesthesia. Then facilitation of the surgical exposure by instilling saline or air through the lumbar drain or mild controlled hypercapnia. Then early emergence and absolute immobility during the surgery. So the anesthetic technique, actually there are no specific protocol. The choice depends on the associated medical conditions and the ICP status of the patient. We can go for either intravenous or inhalational anesthesia. Usually the surgery is of short duration, usually around 3 hours. It's better to go for short acting agents, and appropriate muscle relaxation should be given during the surgery to prevent any movement during the surgery. Usually blood loss will be minimal, and blood replacement may be needed in case if we cause injury to the ICA because it is very close to pituitary tumor, and the recommended fluid is usually normal saline. So induced hypotension we may have to do during the nasal phase, but we have to ensure that the mean arterial pressure is kept around 60 millimeters of mercury, and arterial line is mandatory when performing induced hypotension, and we can institute with dexmedetomidine or nitroglycerin for induced hypotension. So during emergence, we have to ensure that the throat pack has been removed, and we have to confirm with the ENT, with the surgeons, that there is no posterior pharyngeal bleed is not there. A gentle oropharyngeal suction, a smooth emergence is preferred, and the patient is instructed to breathe through the mouth and minimize straining or coughing after extubation. So what are the complications after the surgery? The most common complications are sinonasal complications like sinusitis, septal perforation, CSF leak, hypopituitarism, diabetes insipidus, visual loss, meningitis, seizure, hypothalamic injury, or vascular injury. So the postoperative care, if airway management is very important. If these patients have acromegaly or gigantism, these patients have to be monitored properly in the postoperative period. Appropriate fluids and analgesia has to be supplemented, and neurological and endocrinological assessment has to be done. And diabetes insipidus happens only if more than 80% of the pituitary is damaged. Now, diabetes insipidus, this is usually a central diabetes insipidus. This occurs due to ADH deficiency. The incidence is around 18 to 38%. This happens due to manipulation of the posterior pituitary. So the diabetes insipidus can be transient. That is, it develops for 1 to 4 days after this injury, and it resolves spontaneously. And it can be prolonged. It might be permanent and it will continue indefinitely, or it can be part of a triphasic response. So this is what is called as a triphasic response after a pituitary surgery. 3 phases are there. In the phase 1, the patient will have diabetes insipidus. This is due to the injury due to axon shock and lack of function of the damaged neurons. It usually lasts for hours to several days, and then it is followed by an antidiuretic phase. Here we will see uncontrolled release of ADH from the disconnected and degenerating posterior pituitary. And here this usually lasts for 2 to 14 days. And phase 3, when there is depletion of ADH from the degenerating posterior pituitary gland, here the patient goes in for diabetes insipidus afterwards. So the diagnosis is when the patient has polyuria more than 4 ml per kg per hour, the hypotonic urine less than 300 milliosmoles per kilogram, and the urine specific gravity is less than 1.005. The patients will have hypernatremia. Sodium will be more than 144 milliequivalents per liter, and the plasma osmolality will be more than 305 milliosmoles per kilogram. The treatment is essentially correction of any pre-existing water deficiency and reduction in the ongoing excessive urinary water losses. So in 1.8 to 3.5% hyponatremia can happen. This can happen due to syndrome of inappropriate antidiuretic hormone secretion, or it may be a part of triphasic response after a pituitary surgery, or it can be due to over administration of desmopressin if the patient develops diabetes insipidus postoperatively. Then another complication is hypopituitarism. This occurs in about 55% of the cases. And in 50% of the cases, improvement in hormone function happens. And after the surgery, all the patients have to be screened for hypopituitarism. Then hormone replacement, it has to be assumed that all patients require cortisol replacement for certain time period after the surgery. Then we have to decrease the cortisol to maintenance dose after a few days, and different institutes have different protocols. Usually hydrocortisone 50 milligram twice daily on day 1, then it is gradually tapered 25 milligram twice daily on day 2, 20 milligram once daily, and 10 milligram subsequently. Prolactinomas can be taken off hydrocortisone within few days if more than 20% of the gland is left behind. And if it is Cushing's disease, they may have to take cortisol for up to 3 to 6 months. So summary, when we are dealing with pituitary tumors, normal physiology has to be known, and preoperative evaluation is of prime importance, and we should be aware of the preoperative evaluation process, how the endocrinologist evaluate the pituitary tumors. And pituitary tumors can possess us with many challenges, including difficult airway, management of diabetic, hypotensive anesthesia, management of hypertension, and we should be competent enough to manage the postoperative complications also. Thank you, sir.
Presentation and informative one. I think the floor is open for questions. Gurudev, sir.
Jerry, it was a fantastic narration of the anesthesia for pituitary surgeries. It was very nice and very informative. So one thing I just want to add regarding the Cushing syndrome, which probably you did not cover, is hypokalemia.
Yes, yes.
Can be there. So
yes,
because these patients can also, because serum potassium estimation will be very important, so that that can interfere with our anesthesia, especially neuromuscular blocking agents, and also dysrhythmias can occur. So just want to add that. And one more thing, every book regarding this particular topic keeps telling about either placing a lumbar drain or controlled hypercapnia. So we almost do almost 1 or 2 pituitary tumors in our hospital, but we never do this. And how frequently you do this, Jerry, in your hospital?
Sir, usually we'll maintain ETCO to around 40 to 41 millimeters of mercury, sir. And I have not placed lumbar drain preoperatively for the purpose of instilling air or saline. But sometimes surgeon will ask for placing lumbar drain because they might anticipate CSF leak in the postoperative period, sir. So they might ask for preoperative lumbar drain placement in the preoperative period, sir. Otherwise, routinely surgeons might ask for Valsalva maneuver, sir, to facilitate the surgical exposure, sir.
Okay, till now our neurosurgeons, because it's always a combination of ENT people and neurosurgeons, they do transfemoral surgeries of pituitary in our hospital. But I asked both of them regarding the lumbar drain also, and also about the controlled hypercapnia. So they were totally unaware of this particular thing. I told them that if we produce hypercapnia intraoperatively, you will definitely have a better access to the tumor. But they were, not knowing about this. I also said that why unnecessarily volunteer myself to produce hypercapnia and have problems. So I have never done it.
Yes.
So lumbar drain also I never tried.
Yes.
So that's why I asked you how frequently you people are doing in your hospital.
Yes.
So one more thing I just want to ask you is, you said that the fluid that is recommended is normal saline, because routinely we usually give a balanced salt solution for all patients, irrespective of whether it is a pituitary tumor or any other neurosurgeries. So any special this thing, is it because post-operatively ADH problem and hyponatremia, why you said normal saline may be a fluid that is recommended?
In our institute, we usually use a normal saline only, sir, for neurosurgery cases actually.
So any particular reason? Because normal saline, we know theoretical.
Because it is hyperosmolar, no, sir, that's why. So the incidence of increase in ICP is less when you use with normal saline. That's it, because it has an osmolality of 308. That's why, sir.
No, but there are other theoretical problems like, it can produce hyperchloremic metabolic acidosis, afferent arteriolar problem for the kidneys, and renal tubular damage. There are so many other, theoretical possibilities.
Yes, sir.
So that's the reason why I asked specifically why you want to go for normal saline.
Yes.
Of course, there are theoretical problems. We have not found much as
sir.
such. And we don't use so much of fluid also in neurosurgical patients, isn't it? So
yes,
instead, we actually use mannitol or glycerol for draining the fluid out of the body so that, the ICP reduces. So that is one thing I just want to ask you. Another question I just wanted to ask you is when actually they go for open surgeries?
Sir,
because majority of the time transfemoral surgeries only I have seen
then
in our hospital.
When the sphenoid sinus is not well developed, sir, they might go for open surgery.
Craniotomy.
Yes, sir. Yes, sir.
Or is it depending on the tumor size?
Depending on the tumor size or tumor also, they will decide, sir. Actually.
Okay.
I'll tell you.
Because till now we have gone only through transfemoral approach in our
sir, it depends upon if it is a dumbbell-shaped tumor with an extremely narrow waist at the junction of sellar and suprasellar portion, or if it is a large subfrontal or parasellar extension or a massive suprasellar extension is there, or extremely fibrous tumor, sir. Okay. Sometimes they'll go for both combined approach also, sir. If it is a very big tumor, sir, they'll resect transnasally and then they'll open and resect the tumor also, sir.
Okay. So what is the incidence of CSF leak?
Sir, the incidence is CSF leak is quite low, sir. Actually, they'll place a graft, sir. Actually, so
that is there.
Incidence is less, sir. Actually.
Yeah, correct. We have not come across hardly any case is there. So that is one thing. I just wanted you to tell me about this, OGTT for this growth hormone secretion, how they are related. Because you said that OGTT is done, oral glucose tolerance test is done.
Yes, sir.
Yeah. Can you just explain that the relationship between OGTT and growth hormone?
Sir, if you are suspecting growth hormone secreting tumor, sir, it will not be. It is a the tumor. It will not be secreting. It will not be suppressible by normal glucose levels, sir. So here, what we give is 75 grams of oral glucose is given. So subsequently, we'll measure the growth hormone levels, sir. If it is not decreasing or if suppressing, then we'll arrive at a diagnosis of growth hormone secreting tumors.
Okay. Otherwise, glucose will suppress the release of growth hormone.
Growth hormone, yes, sir.
Okay. No, why the body suppresses the release of growth hormone? Any particular reason? When excess glucose or hyperglycemia occurs, why growth hormone has to be suppressed? Any particular? Or is it a defense mechanism by the body? Because, all these growth hormone or cortisol or all these things are trying to increase the level of blood sugars.
Yes, sir.
So maybe a defense mechanism of the body to suppress the growth hormone secretion, maybe.
Yes.
Okay. So very nice, Jerry. It was, I didn't know about you because I was not there when probably you studied in WIMS. But did you study in WIMS?
Yes, sir.
Must be an alumni of your UG or PG?
PG, sir.
Oh, PG. Very nice. It was, okay. Yeah, very nicely done, and I learned a lot. Thank you so much. Thank you, Jerry.
Okay, Dr. Jerry, you have a question from Balakrishna. What is the incidence of bleeding from vascular injury in transfemoral?
Sir, the incidence is quite low, sir. Actually, the chance of bleeding is from ICA injury, sir, but the incidence is very low, sir. Actually. Otherwise, the blood loss will be very minimal during the surgery.
Okay. I have one question. What about the post-operative pain management of these patients? How do you manage the pain in these patients post-operative?
Post-operatively, sir, usually short-acting opioids, sir. And
my presumption is that it is an pituitary tumor surgery, and because of the manipulations, a lot of endogenous software that are fitted, and they require very low. Requirement of analysis is very small,
Yes,
very
yes.
low.
Yes, sir.
So you do use opioids or opioid sparing analysis
We'll use opioids, sir, actually.
in your setup.
Sir?
Opioids. Okay.
We'll use, sir. We'll use.
So in your institute you use opioids.
Yes, sir. Yes, sir. Post-operatively will be given, sir.
Now, in our institute, we use tramadol and paracetamol. That is the routine post-operative analgesia, because the pain will not be so much. So that is just tramadol. Majority of the times they will be very comfortable.
Okay.
What opioid you use, Jerry? In your
There are also tramadol, sir, for pituitary surgery. Sir.
Okay.
Tramadol and paracetamol is a routine.
Yeah,
Sir.
that is what we also use here.
Okay. Bhaskar sir, I think
Nizam has raised his hand.
Yeah.
Nizam has raised his
Yeah,
hand.
Nizam.
Hello, Jerry. This is Dr. Nizamuddin.
Yes, sir.
I just wanted to ask one question to you. What is the endotracheal tube which you are using during this surgery? Is it South Pole RA or a regular endotracheal?
Yes, sir. Regular endotracheal tube, sir. We'll keep the tube to the left side, sir.
Okay. So doesn't it obstruct the surgeon's access to the surgeon?
No, sir. Usually surgeons will be standing on the right side, sir, and operating, and we'll keep the tube to the left side, sir.
Okay. And most of the surgeries are done in a head-up position, I guess, right?
Yes, sir.
Like,
Head up position, yes,
There
sir.
is increased risk of venous air embolism.
Yes, sir.
Okay. And one more thing I wanted to emphasize, which I had missed, is there is increased incidence of post-operative respiratory obstructive sleep apnea.
Yes, sir.
Because of all the enlargement of tongue and the soft tissues
Yes.
of the oral cavity and all. So there is increased incidence of post-operative obstructive sleep apnea.
Yes, sir.
Okay, very nice presentation.
Thank you, sir.
But Jerry, you can also use you can use an armor tube also.
Yes, sir. Yes, sir.
Yeah, there is no, actually it can be indicated also here, because
Yes.
this head and neck surgery, because whole of the head and neck are covered.
Yeah. Yes, sir.
So I think because we usually go for armor tubes. Yeah,
Okay,
because kinking we want to avoid.
Yes,
of
sir.
course, yeah, that can produce again problems intraoperatively. So because the whole head and neck is out of our reach.
Yes, sir.
So that is one of the problems that can occur.
There are questions from Anand Bangera and Krishna. Bangera has asked a query: Is intraarterial BP monitoring mandatory for transsphenoidal pituitary surgery?
Yes, sir. We usually take RT line for all cases, sir, actually, because usually ENT surgeons will ask for hypotensive anesthesia during that time, sir, during the nasal phase, sir. And most of these patients, pituitary, the acromegaly patients or Cushing's features, they might be hypertensive also. So we prefer to place arterial lines, sir.
Okay.
So, but do you use sodium nitroprusside or nitroglycerin for producing?
No, sir. Usually we'll use dexmedetomidine, sir.
So then why do you want an arterial line for that? Because we don't use any arterial invasive monitoring. Because if you are using only dexmedetomidine and not using any more powerful agents like SNP or NTG, yeah, but maybe it's a routine in your hospital.
Yes, sir, routine. Sir.
Yeah, but we in our hospital for pituitary surgeries, at least we don't use any arterial line. Yeah.
Then Balkrishna has got one question there. Do you prefer extubation for such surgeries with coexisting OSA or obese patients on table?
Sir, if the patient has coexisting OSA or obesity, we usually shift the patient to ICU and extubate after 1 or 1.5 hours, sir, like that only. Otherwise, we'll extubate the patients on table, sir.
Yeah. Just to make sure that there is airway patency and good elimination of carbon dioxide.
Yes, sir. Yes, sir.
Okay.
Jerry, one more question. Do you do preoperative lung function test and ideal before
No, sir. No, sir.
Okay.
Okay. Somebody else raised the hand. Okay. Kiran, that much are the questions only.
Okay. I think.
You are not clearly heard. Kiran, a little bit louder.
I think final remarks from you, sir, and then we'll close.
Yeah, Jerry, one question for Jerry. In your hospital also, it's a combination of ENT and
yes, sir.
neurosurgeon?
Yes, sir. Yes, sir.
Okay,
ENT and neurosurgery, sir.
So same thing in our hospital also.
Yes, sir.
Right.
Okay. Excellent. Sir, anything?
What is the the frequency of number of surgeries that are done in your hospital there in PGA?
Pituitary surgery, sir. Monthly, 6-7 will be there, sir. Monthly.
Okay.
6-7 will be there.
No, because I didn't know that these pituitary tumors are so common, because almost one a week we are doing here. And that means once about 4 or 5 per month also in our hospital also.
Sir.
So it's quite frequent as
Yes,
such.
sir. Yes, sir. Yes,
Yeah,
sir.
yeah. But one thing, you said that in prolactinemia tumors, prolactin secreting tumors may not require surgery. So is there any particular reason?
Sir, usually it is medical management, sir.
Yeah, why medical management? Why better to remove the tumor?
Or else if the tumor is causing compressive symptoms, they may have to go for surgery. Otherwise, if the patient presents early, microadenoma less than 1 centimeter, if the patient has symptoms, we don't have to resect the tumor, sir. With the dopamine agonist, it might suppress, sir, actually.
No, but lifelong they have to be on medical therapy.
Yes, yes, sir.
Right. So that's what, because I had one of my relative's friend, that girl had this prolactinemia because of pituitary tumor.
Yes,
they were treating her medically only. So that was what I was wondering. So why the tumor could be removed so that she'll be totally get relieved of this problem. But bromocriptine is one of the drugs that is used, I think.
Yes, sir.
Yeah, yeah. So, okay, Bhaskar.
And Balakrishna has raised this. Anything, Balakrishna?
Sir, good evening, one and all. Very nice presentation. I just wanted to add one point regarding the role of arterial cannula. So, in our setup, we don't do pituitary surgeries very frequently, and our neurosurgeons are not that expertized. So, I guess one more role of invasive arterial monitoring could be in case if there is an accidental catastrophe on the table, there might be a torrential bleed if any of the vascular pedicle is injured. So then that can result in torrential bleeding, and if we have arterial monitoring, we can get a precise blood pressure at that particular point of time, and it might be much easier to manage by either giving a hypotensive anesthesia or replacing with the blood and blood products, especially with patients who might be obese or who could be having acromegalic features. When we are trying to manage this set of patients with non-invasive blood pressure monitoring, at times when the patient could be hypotensive, the NIBP may not be precise in recording the blood pressure during vascular rupture. So maybe in that way, the role of invasive arterial monitoring for pituitary surgeries could be substantiated. This is my view.
No, exactly. You're right, Balu. The thing is, whenever there is a surgery being performed near a major artery, where there is a chance of hemorrhage, so most of the times they like to put an arterial line. That's what in our institute also, when I was doing PG, any neurosurgery which was having the chances of any injury to an artery or a major vessel, then we used to put an arterial line mandatory.
There is one question about the choice of inhalation agent.
Actually, there is no preferred agent. Here we are using desflurane, sir, for most of the cases, sir.
Yeah. It is much more related to the controlled ventilation and
yes, sir, yes, sir. Or else if the patient has features of raised AC, or else if they are monitoring MEP or visually evoked potential, then we may change to TIVA, sir.
Okay. Right.
Desflurane for early recovery, probably.
Yes, sir. Yes, sir.
Yeah.
Okay. So thank you very much, and thanks, Jerry, for.
Thank you, sir.
Like actually, we did discuss, suppose the focus of the teaching, presentation should be for MD anesthesia students. So we have done it exactly what was required for the postgraduates also. Thank you for the effort and sparing the time. And of course, thanks to all the participants, Gurudev sir, and you got our colleagues from other parts of the country also. Dr. Vishnath Hiremat is there. Then we had, I think, Dr. Vandana is there. So many of the participants are, I think many colleagues of Dr. Jerry are also there in this program. Okay, so thank you very much. Kiran?
Yeah, thank you.